everybody. Yeah, thank you, Shweta. So everybody is eager to hear our guest speaker of the day. This is our sixth webinar of, and the second one of September. And we are very happy to have Ms. Zainab Millwala here for the presentation today. I request our advisory committee member, Ms. Neha Tiwari, to please introduce our guest speaker of the day.
Good morning, everyone. On behalf of Indian Speech Language Hearing Association and especially the advisory committee of the same association, I welcome our guest speaker, Ms. Zainab Millwala, who will be talking to us on this very important topic, that is a roadmap for feeding intervention, the sensory perspective. Talking about Ms. Zainab, she is, as we know, she is a speech language pathologist having 2 decades of professional experience. And she's worked with a variety of children, many children with a variety of speech and language disorders. When I was going through the certificates that she has got, ranging from hand and more than words, talk tools, feeding, assessment and intervention, the prompt, the oral muscular, phonetic targets, the Avaz app, the brain level 101 and 102, and storytelling, and also natural language acquisition professional training programs. Her areas of expertise include pediatric feeding disorders, use of OPT and prompt techniques, and she is actively involved in assessment and intervention of fluency disorders, and also advocates use of AAC. She has given many talks, and she has presented at various platforms. And I'm sure that this presentation is going to be very enriching for all of us. We are looking forward to your talk, Ms. Zainab. Ms. Millwala. Yes, over to you, please.
Thank you, Neha, for the introduction. Now, I hope all of you had your coffee, tea, breakfast. It's a Sunday morning and we're ready. So before we start, let's do something fun. I have 4 riddles. The clue is that the answer for every riddle is a name of a food. So you can unmute yourself if you know the answer and let me know. Okay, so the first one is, I'm a container without hinges, lock or a key, yet a golden treasure lies within me. An answer?
Egg.
Yeah, I heard someone.
Egg.
Yes. Okay, the next one. What kind of cup doesn't hold water? What kind of cup? These are all names of food. What kind of cup doesn't hold water?
Buttercup?
Doesn't hold water.
Cupcake.
Yes, right. Okay, the third one. I have no beginning, middle or end. What am I? I have no beginning, end or middle. What am I?
Donut or?
Yeah, donut. Donut or a vada. Last one. What fruit loves to go crazy and go wild? What fruit loves to go crazy or wild? No?
More hints.
Banana.
Oh, okay.
Okay. So with that, we're ready to start. So as feeding therapists, we all work towards 3 goals, right? The first one being to make sure that our children get enough nutrition and hydration for optimal growth and development. Next, that they become effective and efficient eating, eaters and have good drinking skills. And the ultimate goal that we all focus on is that we can get our child to get included in all the settings that involve food, starting from home, at the dining table, at having meals, and within cultural and social settings. Because if you look at food, every situation in our life, you go out for birthday parties, weddings, housewarmings, picnics, everything involves food. And that is the ultimate aim of the parents also. So with that, if you look at food, let's envision yourself now at a situation at home where food is being prepared. So just think of all the senses now that are getting involved. So the food is not yet come to your table, but what is going on? What are the senses that are already getting involved, right? The food is being cooked in the kitchen. So first you get the aroma of the food. You can hear the cooker whistle going off. You can hear the cluttering of the tongs and the pans. So your senses have already started getting stimulated. So the process of eating is a highly sensory dependent and sensory engaging skill, and it involves all our senses. So as feeding therapists and even as SLPs, getting to know the senses that are involved in the process of feeding, the concept of sensory processing, and what is sensory processing disorder and how it affects feeding is very imperative for us to do a good assessment and plan intervention. Here I'm introducing you to a pyramid. Now, if you look at this pyramid, at the base, we have the central nervous system. Right above that, we have our sensory system. Now, the sensory system forms the base and foundation for learning and development of all the other skills. And if you look at feeding, it goes right up here, our daily living activities. So a feeding is considered this. So for that, it requires a good foundation, a solid foundation of our sensory systems. Now, in feeding in particular, like I mentioned, it involves all our senses. So we have 8 senses that are involved in the process of feeding. And we'll go through them one by one. The first is vision. So like I said, a lot of times before the food even comes to us, the sense that gets stimulated is our vision.
Your voice is not heard, Ms. Zainab. I think your microphone it was heard, but now it is not.
Can you hear me now?
Yes, now, yeah.
Okay. So vision, auditory. Third, gustatory. Gustatory sense needs to develop very early because it helps the child understand what is dangerous, what is safe, what can be ingested, and the things. It also helps them develop their preferences towards food. The fourth one is the sense of smell. So, when we go to a mall and we are passing a coffee shop, we get the smell. That's how they entice us. And it also, the sense about smell is, not only does it help us distinguish good and bad smell, but it is connected to our emotions in the brain. So that emotions trigger either a feeling of comfort or alarm. Next, interoception, which is the 8th sense and an internal sense. It helps the child identify their inner functioning abilities like hunger, thirst, or when they need to use the bathroom. Not able to shift to the next slide. I'm sorry about that. Okay. Now, within our 8 senses, there are 3 senses which are very important. And most of the time when these 3 senses get regulated, we see a very good impact on feeding. Those three senses are proprioceptive. Now, the receptors of these are found in our muscles, joints, ligaments, and tendons. And it allows a child to know where their body is in space. So a lot of times when you say clap, touch your head, touch your shoulder, you know where your body parts are, even without having to actually look at them. The next is the vestibular, where the receptors are located within the ear. So it helps in balance and posture. So it helps the child to identify whether they are sitting, whether they are lying down, whether they are upside down. And then the most important one is tactile. So a lot of times, these two to combine together, if you're looking at an OT's report, they might write somatosensory, because both these sensations work together. So touch, we have receptors for touch across our body. So we pick up and it helps us, along with proprioceptive, it gives us a knowledge of pressure, temperature, and pain. Now we saw all these 8 senses. Now the receptors pick up all these sensations from the environment and from within us. So what happens once the information is being picked up? This information gets relayed to the brain via our peripheral nervous system, that is our cranial nerves and our spinal nerves. Once it goes to the brain, the information gets filtered. So the brain identifies what information is important, what information it needs to block. Then it compares this information with our past experiences and other types of sensory experiences that we have had. And finally, it plans, it develops a plan. And that plan is sent to the specific body parts that need to execute it. Now, if a child is having any kind of issues within this, at any level, then we say the child has a sensory processing disorder. Now, this figure of the brain that you see, most of our senses that are picked up go to the thalamus, right? And then the thalamus takes the information to the central cortex, where the information gets organized and processed to plan the response. So what is sensory processing disorder then? It's a neurological disorder in which the sensory information that an individual perceives results in abnormal responses. For those with sensory processing disorder, sensory information goes into the brain, but that doesn't get organized or processed properly. And hence the responses that we get are not appropriate. So if a child has sensory processing disorders, you can see 3 things. Okay, the responses could be of 3 types. 1, the child could be over-responsive. Now, if they are over-responsive, they are also known as sensory avoiders, because any kind of sensation, it overwhelms them. And this triggers a large amount of, a lot of these children who have over-responsive or are avoiders, you see frequent meltdowns. And in terms of orally, these are children who gag and vomit very often. They have grimacing and they have very strong reactions to certain kinds of food. Then you have the under-responsive or the sensory seekers. So they're constantly looking for sensory inputs. These children will mostly be on the move, seeking out new and novel situations. In terms of food, these children might not feel the presence of food in the mouth and even let it drop without realizing. The third category is low registration. Now, low registration could be a combination of all of this. So in low registration, it appears like, the information from the receptors is not even reaching the central nervous system for the processing. So these children need a lot more stimulation before they start an act of a daily living skill of eating or getting ready. So, identifying the sensory profile becomes very important. Now, if a child has SPD, it can affect them either directly or indirectly. Now, directly how? through the sight of smell, touch, taste, and indirectly if a child is dysregulated. Okay, so indirectly, like we mentioned, those three: hyposensitive, hypersensitive, and low registration. Now, if a child is having these three, either of these three, they are spending a lot of their energy and their time trying to regulate their systems. Okay, so their focus towards food might be very poor. It might be a very unimportant task for them. So they give no importance to the process of eating at all. And then an indirect sense, interoception is also called an indirect sense. Like I mentioned before, it's the eighth sense, right? And it includes our emotions also. So it regulates the appetite or fullness of a child. And also helps them to understand, the gap between each meal. Now, what is the signs and symptoms of our, the direct signs and symptoms? We'll go through all of them. We have hearing. Now, if a child has any processing difficulties with the auditory part, these children will avoid crunchy foods. And every time you see mealtime, they might either cover their ears, and loud situations like a restaurant or a place that, somebody's watching television becomes very difficult for them. If a child has visual sensory issues, the moment they are at the table, they might push back from the chair, they might push the plate away, they might gag or vomit before even tasting the food. So they get confused. If they're hypo, they get confused between all the food that is on the plate. And you'll see these children, repeatedly eye blinking, or you might see watering in their eyes. With the sense of smell, if a child has problem with that, they might generally cover their nose with their hand, or they might turn their head away. You'll see eyes watering. You might see them grimacing again or gagging. Now, if you look at this, most of the reaction, if you look at all the senses, the most common part is gagging and vomiting. So any sense, right? The first reaction is a gag and a vomit. And, they will explore non-food items. So if you observe the child during an assessment, you will see that these children are constantly trying to smell their mother's hair, hold on to their hair, right? And they might not really pick up any strong smells if they are under-responsive or under-sensitive. Taste again, if they're oversensitive, again, gagging, vomiting, grimacing, they might shudder at the taste of something. And if they're undersensitive, at the reaction that you might see or the behavior might be like every food is tasting absolutely the same. Okay. And if they're undersensitive, then you will see them, mouthing a lot of food that they shouldn't be, or they might constantly keep licking on things. And even past, the oral exploratory stage, that's how we judge. Now, the oral exploratory stage generally goes up till 2 years, max 2.5 in children. If it goes beyond that, then you know that definitely the child is having some kind of sensory issues. Okay, the sense of touch. So you will see these children, what they do is most of the time, if they're oversensitive, they will take food off with their teeth and never involve their lips. You will see frequent hand wiping. So they'll keep clearing their hands, and they will not, if you give them a utensil or you place a piece of food in front of them, they will just try to pick it up with their fingertips. So that is where you come to know that they're oversensitive to touch. So the least amount of contact they want to make with the tools or with the food by itself. And if they're undersensitive to touch, they'll be completely messy. They'll have food all over and it doesn't matter to them. They might pocket food in their mouth. They might overstuff their mouth. Body awareness. or proprioceptive. Now, this is important when it comes to tools and holding food. Like sometimes if they have, if they're oversensitive, they might crush the food completely. So they might not know how to hold the food or how much pressure is required. So a lot of these children you will see them pressing on the food very hard, or just letting go of something that if you have given them a tool in the hand, they might just let go of that tool. So they don't know how to handle the cutlery or even use their fingers for eating effectively. Then movement, the vestibular part, if they are oversensitive, startles when chair is pushed to the table, avoid highly chewy foods, they avoid drinking from an open cup. Okay, chin tucked to drink versus backward in space. So if you turn their head, push their head back, they get very scared, right? And fearful when feet are hanging because they don't get that balance and posture. They don't understand that, right? So they get very fearful. If the child has got an undersensitive vestibular system, then you will most often see them rocking or spinning. They find it very difficult, very fidgety, what the parents will say, I'm constantly moving in the chair. So they're very fidgety and they might prefer walking around. They'll keep having a bite or two, they'll walk around, and very rarely they would sit on a chair. Okay. Now, once you understand, what are the symptoms of oversensitive and undersensitive, it's easy to go through the process of assessment. But his mic is on. Okay.
Yes, yes. We can
Continue.
hear you.
Yeah.
We can hear you. Yeah, we can hear you.
Okay.
Yeah.
Okay. So, the process of assessment, now this is very specific to sensory because our target is sensory-based issues. So we collect information from the parents first regarding their food. Now, this was a wonderful study that was done, which showed that when you informally assess parents or ask parents about their opinion about their child's feeding skills, they always underreported the problem because of various reasons. And then when you assess as a professional, when you do an assessment, you find that the child has far greater issues compared to what the parent reported. So that's why a combination of all of this becomes important for us. Then we use structured feeding profiles, which we give the parents. To name a few, you have Bambi. Then you have the Montreal Children's Hospital feeding scale. You can use the behavior pediatric feeding assessment scale. So there are a lot of scales that are available, which you can give to the parent. Then we do clinical observations and we ask the parents to observe the child in various environments. Okay. Now here I'd like to mention one of the clients. I think somebody's mic is on and it's a little disturbing.
Shweta, can you just unmute everyone?
Yes, ma'am. I have unmuted.
Thank you, Shweta. Yeah. And this observation of clients of a child in various environments. Now, with this, I'd like to just mention a child I saw recently. The mother reported that the child is not eating any kind of dry fruits. She said he only likes peanuts, ma'am, but he will not eat walnuts. He will not eat almonds, even if I peel them, soak them in water. So, the first doubt was, okay, the child has difficulty with chewing, or is he not able to lateralize the tongue to form the bolus with those hard, crunchy items? So various thoughts. But then when I asked about whether the child will eat that somewhere else, she said, yes, ma'am, whenever the child goes to the grandparents' house, he will very happily sit with the grandfather and eat peanuts and walnuts and almonds. So she said it's very home specific. And he, it's all right if he's with his dada. He will eat all the food over there. Right? So you need to obtain information about this. There are certain foods the child will eat probably outside, but not eat with the parent. So here I'm not talking, it could be even restaurant food. Okay. And that we will discuss maybe later. Okay, so at the clinic, these are certain forms that we have developed and we use. One is we have a mealtime schedule. So we take information, we make notes on this. So what this entails is first the time that the meal is given. Then the quantity, because this will help us judge the age and the quantity norms that, the amount of food that a child should be taking in. The food that the child eats, here we mark all the variety of foods that the child eats. We note the time taken because even that is one of the important aspects when we do intervention. We do see whether the child is able to come down in terms of time. Then hand-fed or tool-fed by the parent, whether the child is self-fed or both. So most of the time when it comes to snacks, the parents will say that they are eating the snacks by themselves, but when it comes to meals, it's mostly us feeding the children. We also inquire about seating. So is the child's, because posture modulation is again very important. So we ask how the child is seated, and hence getting a lot of videos is very helpful, especially from home. So because you see how the parent is usually feeding the child. So we get that. And here the final one is we ask about gadgets. So there's one child where the parent said that they cannot indicate whether they are full or they are hungry. Whether the child is hungry. So what they do is, because they have tuned her with the gadgets, she will on the gadget herself, and the grandmother just feeds the child. And then when the child is full, what she does is she will off the gadget and walk away. So we collect information based on that. Apart from gadgets, we also ask if the child needs some other distraction, like constant singing or constant engagement in some other form. Okay. Then we have the chart of the signs and symptoms, the hypersensory and the hyposensory. Now, based on that, what you can do is you can use a form like this, and you can make a list of you can make a complete sensory profile, because that would become your target. And generally, this is done along with the occupational therapist. So for each sense, we note down what we have observed or what has been reported. Then we gather information very specific to food, right? And also this information we get from the initial form that we fill up about mealtime. So we get information about their texture. We ask the parents what kind of texture they prefer. Now, it's not always, that they like soft foods or crunchy. There is always sometimes even a mixed, like they would like certain crunchy foods. They might like certain soft foods. Okay. So getting the food list becomes important here, apart from just knowing the specific textures. Color is very important. A lot of times we say that children with ASD orient towards brown, cream, and white, because the other colors are very visually highly stimulating them. Okay, again, if the child is under responsive, so you need to understand that part of it. So we also ask based on color. Next, temperature, hot, whether the child prefers the food cold foods, hot foods, or at room temperature. Here again, we had a child, where the school was highly concerned, because this child would go for hours without eating anything except his snacks, because he required his food to be very hot. So if the food had dropped even to the room temperature, because we know when we give our kids dabbas, it does drop to that level, he would not accept and eat that food. So we had to then think of ways of how to get the hot food to the child, or how could we adjust his behavior or his responsive so that he is okay with room temperature foods. And understanding of the child's preferred flavors gets important. Again, the size of the food, whether they need a large bite. If you see that a child is requiring a large bite, it tells us, it goes back to the child's proprioceptive, right? So maybe the sense of proprioception, somatosensory, proprioception is affected because they need that larger bite to initiate the process, the motor process. So getting enough information of the size is important. Shape, yes, we ask what kind of shape of food they prefer. They like square shape, round, rectangular shape. And then consistency, thick consistency of food, thin consistency, more of liquids. Here, consistency matters because some parents will say that they don't have any kind of juices except water. They will not take milkshakes, although they might eat a fruit, but the milkshake form they don't want to take. Okay, and we also ask about wet and dry foods. So preference for these dry foods and wet foods. Here I will give you an understanding of, comparison, like parents will tell you that they like basmati rice, like they'll eat fried rice, they will eat biryani, but they will not eat dal chawal, or they'll not eat rasam rice or sambar rice. So this information is also important. Okay. Now, although we are focusing mostly on sensory, we need to understand that even the sensory profile of the child could get affected by any of these aspects. So, medical. Now, if a child has, say, constipation or prone to diarrhea, has GERD, gastroesophageal reflux disorder, if they are having celiac disease or any other kind of issue, then medical issues, they could have tonsils, they could have enlarged adenoids. All of these aspects need to be ruled out, or at least you need to collect information based on this, because if we do not take enough information about this, our judgment of the problem the child has would, change. So if a child has got enlarged adenoid or tonsils, he might keep holding the food in the mouth. So he might munch on it, and so we might say, okay, he has proprioceptive issues, or he has a praxis where he is not able to initiate the process of chewing. So it could go to that. So, but he might actually be holding the food in the mouth because swallowing is so difficult for the child. Also, EOE is where, it affects an allergic reaction of the esophagus. When they have EOE again, you'll see that they're not able to eat spicy foods. It becomes very difficult. And if the parent is constantly trying to feed that food and the child is not able to communicate that, they might just keep pocketing that food in their mouth or push it away. So we might think it's a sensory-based issue, but actually it could be a medical-based issue. Then you have behavioral. Now, most of the time, behavioral issues like food aversion or high stress, where they go into fight, flight, or fear mode, is contributed because of a child's previous medical history or a sensory based disorder, sensory processing disorder, where the child, especially with children who are non-verbal and are not able to communicate it. So what they do, their only way out of communicating to their parent that I don't want to eat is by showing a behavior. And sometimes it becomes highly extreme behaviors, meltdown, temper tantrums, and the poor parent is not able to handle this or even understand why it's happening, right? Nutritional issues, make sure the child has no allergies, sensitivities, or intolerance. All these three aspects are different from each other. So you need help with that. You need to make sure that the child doesn't have praxis, that is motor planning disorder, in terms of how to bite, how to chew. Okay, and we have to understand this neophobia. For those who don't know, neophobia, most of the children, this starts at the age of around 18 months. Okay. And what neophobia is, where the child develops this it's happening along with the cognitive development of the child. So they develop like, I don't want to eat this food. And you also see it coincides with the weight of the child. A lot of the times the parent will come and report to you, my child is very disinterested in food. Because at this age also the child starts moving and exploring the environment. So the interest toward food becomes very less. So and they're more focused on exploring the environment. So neophobia is a development of fear towards certain foods, or they have a more skeptic reactions to a lot of foods. So that phase also has to be considered, where the parent says, no, he's not eating any food, not wanting to eat any food. So this differential is important for differential diagnosis. Food jags. Food jags happens where a child who is constantly eating a certain food suddenly stops eating that food, which is sometimes okay, but so the parents can reintroduce that food after some time. So noting if the child has had food jags with certain foods. We also need to inquire about the child's sleep routines, because if a child is not sleeping well, they might not want to eat well. And medication. A lot of times, medication would affect the way the child tastes food. It could alter the taste in the mouth. So all these factors have to be considered apart from just, looking at the sensory aspect. Now, moving on to the strategies. So we look at strategies that need to be followed at the clinic and at home. Okay, so the first and most foremost thing at the clinic, like we mentioned previously, is to find out, okay, the reason for food refusal. It might not be one, it could be more than one reasons. So the reason of food refusal has to be established. The next most important step, I feel, is to establish trust and rapport. So a lot of times, where if the child is not eating, so in fact, even us, when we started off as feeding professionals, we didn't realize a lot of things which we learned across time. So if a child had a feeding issue, we immediately started oral motor stimulation, okay, without establishing the causes and the reasons. So this is very important. You can do that by playing with the child, and especially games that involved some part of the process of eating, like playing with the kitchen tools, right? Next, when you are feeding in the clinic, you need to make sure that the place is very calm, supportive, and stress-free, and respect the child's fears. So we have our 45 minutes and we feel very dutiful that we need to get this done today because it's part of our goal. So we often don't respect the child's fears and we try to, lead them into something else and try to work on their skills, oral motor skills or other skills. So never force tools or any kind of food into a child's mouth. Take parental suggestions and involve them in the process of intervention. Now, this is important because when you are targeting certain foods, you need to know if the parents themselves have it, whether it is a part of the child's, the family's food profile. And we start with progressive desensitization, where we start from the extremities and move towards the center of the body, the distal, proximal to distal. And only then do we move to the face and the oral structures. We include a lot of sensory play with varied textures by using sensory bins. Now, the level of the sensory bin is also planned depending on the state of the child. So if they're not having a wet food, or a dry food, so it goes back to that's why. And also sensory bins are very effective because we have most of our tactile receptors on our palms and on our feet. So in fact, you can make the child even stand on those bins, indulge in a lot of messy play. Again, with the sensory bin, if a child has got any issue with touching, you can use tools. You can use tools that you might probably want the child to start using later on for self-feeding. So you can use a cup, you can use a fork, spoon, okay, and let the child first interact with that before you completely immerse or submerge the child's hands and feet into those sensory bins. Okay, now at the clinic also we follow the SOS protocol, where we actually start with tolerating and then interacting with particular foods, right? So make sure that before you go to the final part of wanting the child to eat, you work a lot at this level of tolerance. Let them be able to very calmly and peacefully look at the food and even know that they're okay with the presence of that food. And then you get them to interact. Next, smell. Then work on the touch. We also call it as snake licks. So when you just ask the child to put the tongue out, just have a lick of the food. And this also helps with modeling. Then taste the food and finally eat the food. So it's a long drawn process of getting the child to eat. So this is for every single food. It doesn't generalize across all the foods. So to maintain that and to form goals, you can choose a certain number of foods that you target, and then you can mark every level that the child is going through. So this chart is really nice. We give it to the parents also, so that even they know it's a feeling of accomplishment when they target and reach every food. We also very strongly use the process of food chaining. It's been very helpful for a lot of our children. Now at home, what do you tell parents? At home, first and foremost, we are setting the stage for eating. And here the child should be at an optimum arousal level. So this is here where the sensory diet is very important. So if a child is very hyper, then they need to get a sensory diet on calming activities. If the child is hypo, falling below the arousal level or very low registration, then half an hour before mealtime, the parents are given activities to stimulate the child. So sensory diet is important. A lot of time using visual schedules for the child gives them a sense of predictability and also a structure. So knowing that, okay, this food is going to start at this time or this is meal time, and it reduces the stress level of the children. This is also particularly very helpful when you're working with children who have poor interoception. So you'll have parents who tell us that, ma'am, my child can go without food the whole day. They will not at all ask. So a lot of us have concern, it's an internal sense, so how do you work on it, right? So you can work on it through visual scheduling. You can also use AACs for this purpose to indicate mealtime expectations, what food is going to be served. So the child gets mentally prepared. The mama can show or the parent can show that today this is for lunch or this is the snack you're going to have, or help them make choices, right? And to show the preferences, or to even basic thing to indicate whether they want to eat or they don't want to eat. And this part, which we call as exposure. So exposure and immersion. Exposure is where we tell the parents. So looking at it from a very practical perspective, we sometimes initially used to give our parents a long list of things to do. But we realized, life is hectic. It's not practical. So the first and foremost thing we tell them, just take the child to the kitchen or just take the child to the general market and start from there. This is something that is doable. So let them help you wash the dal, put it into the cooker, put the masalas, do the tadka, chop, give them a safe knife, let them chop certain vegetables. So that is called exposure and interaction with foods, where you get them to even smell. So stimulating all their senses. And the most important part here is that sometimes parents want them to eat very soon. So what they do is once they mix the salad, they will say, okay, now you eat. So without forcing the child to eat, this exposure state has to go through. Then teaching them food specific strategies. Presentation of the food really matters. We have also seen at the clinic, the way we plate the food makes so much difference to the child. And initiate with very small quantities. Sometimes even like a speck the size of a pea is enough to be present on their plate. When you are selecting a food, take care of the textural preferences. Okay, and this is mostly during the process of food chaining. We follow that process. Don't introduce too many foods at a time. Go one by one, either in two categories, right? So if the child is eating, say, biscuits, then you want to move on to another type of biscuit. So and if they're eating, say, like a pulao, then you want to move on to another type of pulao, not directly go into soft rice. Now, at the table, the strategies that you could tell parents is make sure the seating, a lot of it has to do with posture, especially if the child is having any kind of reflux issues. So we tell them to seat them at a 90, 90, 90 and provide good support at the feet. Now, if you can think backwards, you know that this is very important for a child who's got vestibular issues. Also, providing good support becomes integral for a child with proprioceptive issues where they don't feel enough pressure. So when it comes to babies, giving them wrapping them in a little towel gives them that proprioception, and hence the feeding is much better. Minimize distractions and have a conducive environment. So the lighting matters, the sound matters. A lot of the times when parents are in a hurry, child is sitting at the slab of the kitchen and the parent is doing something and trying to feed them. So make sure that, parents could be told that feeding is not only for the purpose of feeding, right? This is the time where you are bonding with the child. This is the time where you are teaching language and communication. So it serves a far greater purpose than just getting the child to eat. This rule is called the rule of 3, where you have the preferred food, a less preferred food, and a non-preferred food. So the non-preferred food could be as a set of a pea, and the parents need to be told that suppose the non-preferred food is creating a lot of distress in the child, then please, for some time, let's not eliminate it, let us do it. And if a child is not eating properly, what the parents allow is food grazing. Because they feel, whatever the child takes in is okay. But this should not be allowed. Instead, what the parent can do is provide short, frequent meals every 2.5 hours. Limit the meals, have a stipulated time. Again, very important for children with interoception difficulties. Keep it to 30 minutes max. Then shift to another activity. After 2.5 hours, again, get them to the activity of eating. And if a child is having difficulty seating, that would be one of your targets, that the child will learn to sit at the table for the complete meal. But before we start with the small steps, progressively increase the time that you want the child to eat. And the best way is by using timers. Now, beyond the table, provide specific food-related information. So there was this child who loved running around. So, and as he was running around, the father was eating chapati with sabzi, which the child had never eaten actually. But because he was running, he took a bite and he actually ate that food. And then that food got, added to the list of the child. So give specific. So what the parent needs to say at that time is just not applaud or say, very good, but give an applause, give a specific reinforcement stating, today you ate chapati with sabzi. Very good. Okay, so food specific, and never use junk food or snacks that they prefer as rewards. Use a positive role model at home. Get the child to eat at least one meal. That should be your first goal. Get the child to eat at least one meal with the entire family. And I give a lot of importance to the sleep pattern because, like I said, both adversely affect each other. So it has been shown that if a child has difficulty with sleeping, it could affect the child's gastrointestinal functioning. So get this also in place, right? So there is just one, I could not get the videos, I'm sorry. I would have loved to share that with you all. But this is a child which showed us very good progress just within 2-3 months. So this child to us, age 6 years, he started coming to us with with difficulties with language, communication, and speech. And like I said, his mom did not really report his feeding difficulties. She said, no, that's happening okay. Only when we started working with the child and we saw that the child had actually oral motor difficulties, we thought of inquiring and probing further with the parent if the child had any feeding issues. And that's when she told us that, yeah, he has feeding issues. So when we started off, this was the level the child was at. He showed a lot of distress on seeing certain food. He gagged and vomited with soft foods like sambar rice, rasam rice, idli mashed and given. He was very reluctant to touch any foods. He refused all liquid intakes except water. He preferred only crunchy foods like almonds, and that too it was a munching. He did not have rotatory. Every meal took the mother around 45 to 50 minutes. He was force-fed, so he was literally locked in by the mother's hands and legs so that, she could feed him and send him to school. He had a lot of pocketing of food. The total number of food that the mother reported that the child ate was only 6. There was no fruits, no vegetables, juices, milkshakes, nothing. And he just self-fed for these 3 items, almonds, biscuits, and, he liked French fries and Cheetos. So this was the only thing that was there in his diet. His physical and oral motor skills, the child had developmental delay, which resulted in poor gross and fine motor. And he had difficulty with coordination, weak core strength, and poor postural control, which hindered the positioning of the child. So this part was taken care by the OT, and we worked together on this. Again, oral motor difficulties. When we gave the food, we saw that there was no lip seal over the spoon, poor tongue retraction, poor lateralization. Rotatory truing was just emerging. He could not form a proper bolus, especially with the almond and all that. It was spread all over his tongue. And we saw decreased oral transit time. Okay, so we used all the strategies that we have mentioned to you. We did a lot of exposure and immersion. Now with the sensory bins, it's not only done at the clinic, but just like medication, we prescribe how many times the sensory bins and messy play should be done across the day. So we tell the parents, make sure, depending on the difficulty level of the child. So with this child, he was okay with the dry sensory bins. So we very quickly moved on to wet sensory bins and messy play. The occupational therapist along with me we started off with the SOS method also. So where he didn't like the touch of food, he would gag by even looking at it. So we started putting it in Ziplocs for the child. It was often put into Ziplocs, and we just wanted him to, press on those Ziploc bags, which he found a lot of fun. We used the food chaining protocol, especially with the crunchy foods and the dry foods, and he moved very fast on that. With rice again, this is a child who ate only biryani, basmati rice. Okay, so then we moved on to, having pulavs. He didn't like anything white because, he had a negative association with that food because he was being force-fed all the time. So So to get to that, we use the food chaining protocol, crunchy foods and dry foods simultaneously. We taught the parent how to do facial and oral desensitization, and we did it again at the clinic. We did a lot of postural modification. Here, the child was always made to sit on the ground without any kind of support. Now, if a child has core issues and poor postural stability, he was actually falling left and right or showed disinterest in the food after some time because he must be getting tired of the process. We modified the feeding issues. For example, with water, the mom kept pouring the food in, right? So we taught her methods where he can learn to use his lips better with a spoon and how he could be better. After 3 months of intervention, which I did it along with my occupational therapist, the child is now mostly eating all textures of foods. We have 25 food items and 5 food drinks that he has. He enjoys tea, coffee with the mom and the father. He's self-feeding. We have a lot of videos. He's self-feeding with a fork and a spoon. And after every 2-3 bites, he keeps doing this, for his appreciation. So I told the parent to do that. No more gag reactions with food. In fact, he shows a lot of excitement. The feeding duration is come down from 20 to 25 minutes with meals. Orally, very good lip closure now on his stools. Tongue lateralization is improving because he has motor difficulty. Better retraction and better bolus formation. So now we have a little boy who enjoys all his meals and eats very well. Just to sum everything up, as caregivers and parents, it's very important that we understand what our final goals are with children. And feeding intervention could be a very long process. It will require a lot of patience and perseverance from our end, and also we need to convey the same to the parents. Apart from that, it has helped. You need to be on top of your mind. You need to be highly creative, especially when you're working with children, because every child is so different. Every child will have a different profile. So being creative is very important. Not all strategies are applicable to all the children. And we are still learning. So there is never a phase where you know it all completely. So, don't be worried about trial and error. Keep trying. There could be, it might work, it might not work. And keep educating yourself. I think that is very important. Clinical experience alone doesn't help. So please go through latest research and things that are happening in terms of food. And aim to make meal times a pleasant and fun experience for parents and for the child. Thank you.
Thank you. Thank you so much, Zainab. And there was just request during your presentation, the checklist which you mentioned earlier to screen the feeding and sensory information. If you could just put the links or any PDF sharing in the chat box. That was one of the requests from the participant.
Okay. Do you want me to mention it or just put I don't have a link. It's more, I have a hard copy. So
okay.
If someone wants it, they can email me and I will send it to them. Right?
Okay. Okay. So I hope participants have noted your email ID here.
Yes, you can always, it's always good, to, if you have any doubts also, in fact, regarding any child that you are seeing who is having any sensory based issues. So please, feel free to email me. I will try to help you all out and also learn from you all in the process.
Okay. So we'll take questions now.
Zainab, are you listening?
Yes. Yeah.
Well, first of all, thanks a ton for a wonderful, very comprehensive and presentation, a topic, in which not many people know much about, but since there's a lot of hype these days about feeding and parents are getting aware. So I feel, professionals, despite not having any, experience, have started to work on it. I wanted to know a few things. First, how do you basically differentiate between a child who is having sensory processing deficit versus a child who's got sensory, who's got food preferences primarily due to parental style? some parents just say, oh, isko to pasand hi nahi, ye khata hi nahi hai. They've never introduced that food material to the child, and they just keep on saying it, that their parenting style is such. So how do you differentiate it from, just a child having a food preference because of parents, and having a child or a child having a food preference because of sensory processing difficulty?
So, Neha, with this, like I mentioned before, it's very important to ask, get the parent to tell you what food is being cooked in the house, right? And a lot of times, again, there was there was a study that was done which showed that the kind of foods that a child eats is very much related to the kind of foods the parent was fed as a child and exposed to as a child. Okay, so you need to ask suppose, certain foods like, say, capsicum. Now the mother herself will say, I don't like it. Yeah, so this is what the mother did not like as a child, or something that was not introduced. So sometimes going back to the parental history of their preferences gives us a very strong indication of what the child, the sensory profile of the child. So getting an understanding of what is cooked in the house, how many times a child is exposed to those kind of foods, and the parents' preferences. So do you like that food? I ask them many times. No, I also don't like it. So that's the response you get. So that really helps us understand which is a part of a child's sensory profile, or whether it is not, the child is not accepting that food, right? Because the parent doesn't like it, or the parent has never introduced it.
Got it. One more issue that I hope this helps all the other participants too. A child with sensory processing difficulty, there will be nutritional deficiencies too. But I have not seen many SLPs actually referring children for the nutritional deficiency profile. I feel that would be helpful, and I would like to know your take on it.
Yeah, Neha, like I said, when we started a decade back with sensory issues, working with that, very less knowledge we had about it. So we wanted to be the lone captains in the process.
True.
Yeah, like I
Yes.
will handle it. You have a feeding issue, I will handle it. But in fact, with years, you have realized that you can't, you have to share the captaincy. We are not going to do it alone, right? So now we recommend to a GE, we recommend, if you suspect any medical issues, I send them to a gastroenterologist. We get their feedback. Okay, medical system is clear. Next, nutritionist. Again, when you choose a nutritionist, make sure the nutritionist knows enough about SPD, because we've had experiences of the same, right? So can they recommend foods first, which is within the preferred range of the child? They can't give a listing of foods and say, make your child eat all this, and this should be the quantity, and this should be the foods for the child. Also taking into effect, the GFCF diets that most of the children are on. So you need to make sure that the nutritionist you refer to has enough sense about sensory processing and can give food range within that. So yeah, you have to have a nutritionist, right? If you're working, developmental pediatrician is very important, right? So you cannot do it alone. You have to include everybody.
With that, I would like to ask this question being asked by Abhishek Philip. How do you do transition from soft food to solid food consistency?
Abhishek, like I said, it can be planned for every specific food, right? So you need to know why the child is not going to solid foods, why the child is at a pureed level. Okay. If that your question is, so like I said, we make a note of every kind of food that the child is eating and not eating, why the child is not eating, or why the child is not transitioned from a pureed to a solid food yet. So what is the reason? So the why is very imperative here. You need to know why. Only then you can transition the child from soft to hard foods.
I have one question, Ms. Zainab. See, from developmental pediatrician, as you rightly said, the team is huge who's dealing with the feeding issues and children, especially with autism. Okay,
Yeah.
with sensory, oromotor sensory issues as well. So usually in my clinic, what we find is the doctor is sending the child with all the medical clearance and all that, but they also have been there also have been suggestions of keto diet. So first of all, the child is having oromotor issues, then the parents are not very well educated, or maybe the environment in the house is not such that they can actually afford to make a separate food for the child. And on top of it, they are set to give certain food in very large quantity, and rest of the food totally neglected,
Correct.
like milk cut
Correct.
out, sugar cut out, and all those things. So I just wanted to know, how is your take on it, and do you experience such things? So because it is very difficult for an SLP to work on feeding when there is so much less, like if I say something, the mother says, no, no, doctor has said don't feed this to him. Okay, if I say fruit pulp, she said no, no, he's not allowed. So there are so many things which hinders my training of sensory, oromotor sensory preparation for the feeding. So how is your experience with it, and what do you tell such parents?
Here, I work a little against, what the doctors have to say. Sometimes, because now a child is eating, just say he's eating only curd rice, okay, dahi chawal, and having one type of a biscuit. Okay. Now, giving a diet for that child makes no sense, according to me, right? Because he doesn't have a lot of food already in his range. So the first and foremost thing is to get the child exposed to a lot of textures to build up. Once sometimes when the child have a wholesome diet, is eating everything, then the mother can make, or the parents can come down to the diet that is required for the gut, right? Because gut health is very important. As we all, the gut microbia, that's a different ballgame again, that can actually change the bacteria in the tummy, can change how you perceive or taste foods. It completely alters that. But so there are a lot of things. So what we started off with one of these kids was that, yeah, she was only eating a biscuit. So first I wanted her to start eating more foods, right? So you can only build on feeding skills if you expose the child to more foods, right?
True,
So,
true.
so sometimes we start large and then you could go to the smaller diet. I feel we could proceed like that. It's been helpful for some kids that
Yeah,
way.
so sometimes we need to maybe call the doctor and talk about these issues,
Exactly.
and
Yeah.
get over with it. Yeah.
Yeah. Yeah.
That's what, like, I was thinking, like, I have called couple of doctors, and then I was like, am I doing this within my area of professionalism, or I'm going away and doing something
No,
little bit
if anyone
extra?
has something more to add, definitely please. But this is what I think personally. Unless the child has some problem like EOE, or is got intolerance, allergies, sensitivities, then I will definitely not include those foods in my list. Okay, so that has to be kept in mind. If their child has no issues with any of these, then please proceed with trying a
Namita,
larger range.
I would like to add, when you said that you actually have spoken to doctors about a particular case, I feel it's a responsibility to do so. When we say interdisciplinary approach, it's not only just referring or getting a referral. It's also about talking and discussing, because that augments our knowledge. It could be something that we have missed in our history, that we could get information on by talking to a medical professional
Yeah,
or
yeah.
some other professional.
No,
So
it's something like, the doctor's talk is something like, you are an SLP. You are not a nutritionist. You can't talk about these things to me.
can't
That kind
change
of,
their,
yeah.
we can't change their this thing, but we do that in our setup. We talk to tutors, we talk to special ed, we talk to counselor, we talk to. So I think you are trying to have
Good to
everybody
know.
in the team,
Good
and
to
that's
know.
Yeah,
good.
in fact, a lot of schools also, we can step into a lot of schools that we write recommendations and give, that please consider this child is having, a visual issue. So if it is mealtime, you please take the child out. So like I said, you can't work alone on this. Okay, no one knows more than the other. We have to work together. Right? Yes, we work together. Only sometimes we oppose when we have doctors who will come and parents who have come at a much later time, where the range of food has become so tiny, because they've always been told, or the parent is guilty at home that you are not feeding the child enough. So they're even scared to get professional help because they think it's because of them that the child is not eating. Right?
No,
Or
I mean,
the
I
doctor has told them.
I see sudden change post pandemic. Like initially we had to tell the parents, go to the doctor. Maybe it's vitamin deficiency, or maybe it's allergy, or maybe get those tests done from a doctor. Now they come with a whole set to me. Allergy test is done, gastrointestinal testing done, all blood test, urine test, everything is done. And they come to me with that whole bunch, like everything is done. Still he's not eating, So that is, the awareness is also raised. Great to know, but good to know that you all are doing this in schools and the clinical practice. So so I'm not wrong anyway. That's just wanted to know.
No, I would like to add here, Namita, the school where I work, this child again with I would not say sensory processing disorder, but then the child had food preferences, and inclusive education is in place in this particular school. So, and we have a common lunch for everyone, for all the children. For this particular child, because he would not eat that particular lunch, which was being given to everyone, the school actually raised its bar to, to such an extent that they asked us, they asked the doctor, and we sat together and we prepared a little plan for him. And we also introduced a little bit of what other children were eating, small portion. But the larger portion was what he wanted to eat. So we still at this level only. I'm keeping my fingers crossed that slowly, we'll be able to increase the portion size.
I think creating awareness is first very important. Correct, Neha. Yeah. Because it's very less knowledge. And like I said, parents underreport. Or they've been told by the doctors that it'll come about. It'll come about. You don't need to work on it. He will start eating. Right? So yes, I think we are growing, and the first and foremost is, let's spread our wings and spread awareness about this at every level where the child has to actually eat.
Yeah, true. Are there any more questions?
No, I cannot see any questions.
Hello, can I?
Yeah.
I do have a question. Yeah. Zainab, very nice presentation. Neha ma'am and Namita ma'am also nice, good learning from you. I had a question in the sense, the under-responsive, the symptoms that you talked about in under-responsive, that they're fidgeting, they move around, can't sit in one place. Isn't it like something relate to hyperactivity? Do you see hyperactive? Would you know? Would you have hyperactivity as a different term for them?
See, under-responsive, right?
Yeah. In
You were asking about under-responsive. So under-responsive, it could be, if you're looking at ADHD, it could be hyperactivity in terms that they're constantly moving. But if you're looking at the responses, okay, where, if a child is poor proprioception, you will see that they all constantly want to jump on certain things because they need that pressure in the body, Mitali. So you will find these children moving, leaning on chairs, leaning on to parents. So movement, I meant that way. In terms of being hyper-responsive, they are seeking pressure. Does that clear the doubt?
They're seeking pressure, but they're moving around also. They're fidgeting, they're moving around. So you don't mean they're hyperactive, active?
They are, okay, it could be both, the Mitali. They are moving around because you could have, if you looked at what I have given, a child could have a mix of issues. It's not only hypo or it's not only hyper. Sometimes they could have a combination of a lot of things.
I would like to add into,
Add into
what.
that, Neha? Yeah.
Yeah, just let me know if it's understood. See, Zainab correctly mentioned, she specifically went into the details of various senses. So here you're talking about one particular skill, motor skill. The child is just running around, right? So very true. The child is hyperactive if you look at the physical domain. But if you also look at the child's sensory requirements, if the child has this particular proprioception issues or interoception issues or vestibular issues, then you say the child has sensory processing issues too. So yes, as Zainab correctly put forward, this could be a mixture of both, but then we have to be very sure of whether we're looking at a child, a hyperactive child, or a child with hyperactivity because of sensory processing issues. I hope that is clear to you. So there's a fine line, and it all depends upon how well versed we are and how observant we are. So I think we may go wrong in the beginning. I would admit that. But then let's have this thing theoretically very clear in our mind.
So that, Mitali, really, we could get a lot of inputs for this from an OT, right? So
Okay.
we are not able to make the diagnosis ourselves with this in this aspect completely by ourselves. 100% we need an OT involved.
Okay. Thank you, Zainab.
So there are questions in the chat box, I think.
So there's a question, ma'am, in your case presentation on strategies, you mentioned modification of feeding methods. I want to know what all is included in it.
See, modification of feeding methods happens after you observe how the parent is feeding the child, right? So the kind of bite size they are giving. Now, if a child is gagging, for example, and the parent is giving, very large quantities. So that is what modification means. Okay. How the spoon is being put into the mouth. Are they just going through dumping? Some of them even rub the food off the palate, right? Just to make sure it's going in, it's going in. There is no gap between the bites. So the child has not yet taken the food in or not swallowed yet. And the next bite is given to the child. So these is the modifications you make purely based on the observation you see of the primary caretaker feeding the child. Like water being poured into the mouth, large quantities. Again, the child would gag or cough if he's not able to motorically handle that quantity. So then, asking them to start with smaller sips, giving better control to the child himself with the liquids, monitoring how much of liquid goes in. So these are all modifications. That's what I meant by modifying the process of feeding.
Neha, you are on mute.
All right. Thanks, Zainab. The next question is, what counseling or feeding techniques can be given to clients with esophageal motility disorder?
With this, I haven't seen, frankly, because we work a lot with children with ASD, and ASD kids come up a lot with GERD, reflux, because they have feeding issues and they're only on certain diets which are high in lactose, like, milk and all of that. So then if I'm referring, I send them for that. So I send them to the GE just to rule out these things. So in my experience, because I work mostly with GDD or ASD, ADHD, Down syndrome, I haven't come across any report that says, mentions this issue. So if anyone else can have anything to say about this, please do.
Even I have, because I don't work in the individual phase of swallowing. I don't work, so I cannot. Anyone else in the audience, among the audience, who would want to answer or give his or her views on it? All right. So now, question by Lavina. Ma'am, you said with respect to the fears, how do we do that?
Okay. Now, in respect to the fears, it's a very broad-based question. But if I see a child, for example, we had this kid, Lavina, who we opened a pomegranate box, right? And she went into flapping, okay? And she had a meltdown just by looking at a box of pomegranate, which was kept at the other end of the table. Okay, even this kid who I mentioned, who had a difficulty, the case study, the moment we opened a box of apple, he had a meltdown. He started screaming, no, 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 no. Okay, so this is the fears. So respect their fears, right? So if I see that the child is having difficulty with this particular colored food, because she's not going to get the smell of pomegranate, it's really far. So that's when you know that the child is actually has so much fear regarding that food. So what you want to do is first start with the first step, which I said, tolerance. Get them to tolerate it. We even use picture books with a pomegranate. Or what you can do is go up the food color hierarchy. So start introducing them to food visually that is of one shade lesser. If the color red is very overstimulating, then we would start like say with oranges if the child has no kind of food. So start on the go from the lighter and then to the brighter colors. If pomegranate is your immediate target, then like I said, what we do is we just keep it in Ziplocs far away within the environment, and we tell the parent the same thing. Just keep it around. The child doesn't have to interact with the food at all. Just get them to tolerate. So this has been very helpful, and this means respecting their fears. You don't want to keep it in front of them, look at it, to feel it, to touch it immediately.
The next question is by Mitali. How do you distinguish motor issue from sensory issue in a child with cerebral palsy?
Cerebral palsy, I think, Mitali, with again cerebral palsy, very few clients that I have seen. But if you're talking in terms of ASD, the distinction comes because they have praxis issues. So a lot of the times you will come to know because they are allowing you that texture. And I think the same thing with a child with cerebral palsy. They are okay with all the other senses, right? That's a big giveaway. They can see the food. They are able to smell the particular food. So what you do is that hierarchy that I mentioned, right? You make sure that the child is crossing each level, okay at each level, and only at the final level that you come to eating. If it is an issue only at that level, then you know it's a motor-based issue, right? If all the other senses, they have no issue at all, they're okay. And if it's a child with cerebral palsy again, you need to know what kind of cerebral palsy and what is if they're having certain reflexes. So there's a lot that goes into cerebral palsy. But if I'm working, I have seen spastics. So we first rule out all these sensory issues, that they don't have any other issue. Then we know it's only specifically motor-based issue.
Okay, so right. So I don't see any more questions. I would like to take this opportunity to thank Ms. Zainab for the wonderful presentation, very comprehensive. And I'm sure each one of us who have been listening have benefited immensely. Any doubt, any question, Ms. Zainab has been, very generous in sharing her email ID with you all. So you could post your queries. And thanks again, Zainab, on behalf of the Advisory Committee of Indian Speech, Language and Hearing Association and our chairperson, Dr. Namita Joshi. I would like to say thanks to you once again. Thanks to all the participants too for the patient hearing and all the questions. So we want the sessions to be interactive, and it's great to have questions and brainstorming on those. So thanks once again. Bye. Have a great day.
Namita. Thank you all. Have a good day, everyone. Bye-bye.